Good morning again, everyone. It's Melanie Mock and the team here at Kentucky Hospital Association. Thank you so much for joining our quality program educational webinar on readmissions today. We do ask that you please mute yourself if you're not speaking, as we will be recording the call today so that we can put it up on our website and also send it out to you guys in our weekly newsletter after today. A copy of the presentation will also come to you via the email, weekly email, and we'll make sure to send that out. As a reminder, we do have the readmission checklist form in the chat box for you to download today at your convenience, and we'll send that out with a copy of the presentation also. At this time, I'm going to turn it over to Charlie Kendall to start our program today.
Thank you, Melanie. Good morning to everyone. So nice to see everyone. And welcome again to this webinar on readmissions. This is our agenda today. We'll be introducing some new staff, one of our new staff members. Then I want to talk about the checklist that Melanie referenced. And then we want to talk about community collaborations. And we've got two folks, Lisa from Taylor and Becky from Baptist Health Hardin, that I'm going to have share some of their experiences. Probably the most important thing that we all need to understand is that the reality in which we find ourselves. We have just come through 14, 15 months of worldwide pandemic that has just played havoc with the way in which we've had to operate in our hospitals and in our healthcare. And nowhere is that more evident than in readmissions. It became very, very difficult to have any kind of consistent processes in place during the last 14 to 15 months. As we adjusted to infection rates and death rates and community spread of COVID, it was very, very difficult to not only maintain some of the good practices that we had in place, but the patients changed. People were afraid to come to the hospital and delayed coming. And when they did, they were in serious shape. Others were afraid to go home. They had the supports that they had at home were less, or they were very, very concerned about catching COVID. The use of senior citizens centers in our locations, which oftentimes provided a means of double checking the health of many of our older patients was gone. So we really had a very, very difficult time.
But he uses ACE routes for fluid for edema.
Yeah, we really had a very difficult time keeping track of readmissions. And so we thought that during this webinar, what we would do is to try to go back to the basics and to try to level set again about why do we even worry about readmissions? What are some of the things that we can do to prevent readmissions to our hospitals and to slowly begin to rebuild our toolkit. And we want to start, first of all, by introducing our new staff. This is Kayla Rowe. She's a licensed social worker and a certified community health worker. She came to us last November from a career with Passport Health, now Molina Health, where she, in fact, was a case manager. In addition to that work, you can see on the screen there that she had worked as a social services worker with Commonwealth of Kentucky, where she worked with Crimes Against the Seniors Unit. She's currently working on her MSW at the University of Kentucky, and her specific role with us is to work with our QIO/QIN Alliant Health partner in creating and nurturing our community coalitions. And as you can see there, many of you are part of our coalitions, and you know what they do and how we use them to come together to solve community issues. Okay. This is our checklist that Melanie referenced, and it's in the chat. This was left over from our work with the CMS program, Hospital Improvement Innovation Network, that many of you are familiar with. And we found it to be a very valuable tool. We've recast it a little bit to divide it into two major pieces, one being process change and then regular monitoring for compliance. And when we would visit hospitals to start the dialogue about readmissions work, we would go through this checklist to try to help hospital quality and case management folks understand, here are some of the things that we know work. Here are some of the things that you can assess yourself as to your preparedness to do quality work with preventable readmissions. And it was a very good way for us to begin the dialogue. One of the most important things that you need to know is your numbers. Oftentimes we talk about trying to impact change in some way or the other, and we talk about it usually in terms of we're going to reduce something by X%, or we're going to over baseline, and we come up with these various goals. But oftentimes, what is most important for us to really know is how many patients is that really? And we had quite a number of aha moments back when we first started focusing on knowing your numbers, as people began to say, it looked daunting to try to reduce my readmissions by 12% or 15%. But when I looked at it, that's one patient a week, or that's 3 patients a month. So the most important part of working on preventable readmissions is the very first item on our checklist, which is to know your numbers. How many people are being readmitted? What are the demographics of those patients that are coming back? How often are they coming back in terms of how since their discharge? Are they coming back within the first 7 days? Are they coming back within the first 14 days? Are the COPD patients coming back with greater frequency than other patients? So the most important part as we begin to reset with regard to readmissions is to understand our numbers. And to help us understand our numbers from a global perspective, I've asked Melanie to put together some of our Kentucky readmissions data. So, Melanie?
Great. Thanks, Charlie. As Charlie said, this is a state view of our readmissions data that you manually enter into the Kentucky Quality Count system. We've been collecting this data for quite some time. We know that there was, during the 2020 calendar year, many of you were not able to put in data due to obviously taking care of patients every day during our pandemic. But I did want to show you kind of where we are. I pulled in several years. So we looked at calendar year 2019, and that is in the blue. We had 80 hospitals participating with the 30-day all-cause, all-payer readmission rate. And you can see where we were in 2019. The orange or red line is the calendar year 2020. Now, again, we know readmissions increased, decreased, and went back up in 2020 due to COVID. The other thing to note with the 2020 calendar year data, we only had 70 hospitals submitting the data at that time. That is not to say that you can't go back in and put the data. The key is making sure we have as much data from a state perspective in order to make true change when we're talking about readmissions. We also wanted to add in a little bit of the 2021 data. You'll see that in the green line. And you can see kind of where we are. Again, noting there's 64 hospitals participating and putting that data in. It's going to be vital for many of our programs that we are doing so that we can see what we're doing with our data, and so that we can work with you on an individual hospital perspective. In Kentucky Quality Counts, you are able to pull your data and look at it from many aspects. You can look at a run chart. You can look at it from a peer-to-peer comparison. So if you wanted to know where you are compared to where your like-size hospitals are, you can do that in the Kentucky Quality Count system. If you do not have access to the system, please let us know, because again, this is vital for you to be able to know your numbers. Also want to share with you the Medicare only rate. Again, this is from our Kentucky hospitals data. Again, you can see calendar year 2019 is in blue, 2020 is in the orange red, and then 2021 in green. We always make note that our Medicare only data, again, hospital-wide all-cause unplanned readmission rate, Medicare only, always a little bit higher, knowing our population. And you certainly can see that in the calendar year 2020, especially during the pandemic, where we see spikes in the March, April area, went back down in the summer months, and then spiked up in the fall. So we want to be able to share that with you. Again, this is data that you can see at your level in Kentucky Quality Counts. And you can, again, compare yourselves to like-size hospitals if you would like. The other data that Kentucky Hospital Association is looking at on readmissions is Medicaid only. We are utilizing our KHA claims data to start looking at Medicaid only readmissions data. I do not have a graph of that today, but you will start to see that by hospital in Kentucky Quality Counts and then from a state viewpoint. This will help with, if approved, the Hospital Rate Improvement Program quality initiative that we have proposed to CMS. So we are reaching out to those hospitals with elevated readmission Medicaid rates and start looking at that particular population also. Other data that we're able to share with you in the communities is from our partner, Alliant Health, where we look at reducing hospital readmissions, again, Medicare only, but also pulling in the other post-acute care providers within the data. This is a graphic that you will see when you come to the community meetings, and we will share that data with you. Now, you'll see a couple of gaps in the data, and you're probably wondering why there's a gap. Alliant, in working with the CMS contract, CMS decided to change the definition of how they were using the data. So there is a gap in the data at the moment for Medicare only, and we will update that graph and send it to the communities as we receive that updated data. The other thing that we show at the communities, which we think can be helpful, although this is a very busy slide, don't get too much into the details of it, but it basically shows a viewpoint of the communities and where they are with reducing hospital readmissions. Again, looking at Medicare only here. So we have a couple of ones. We have all payer, we have Medicare only, Medicaid only, and we can look at that from various ways. The other thing I want to mention regarding data is KHA recently established Tableau dashboards in our Kentucky InfoSuite product. And the reason I want to mention that, and you all will have access to it if you would like, we've incorporated census data. And that allows you to really kind of drill down from your community perspective in looking at things like language, educational level, and those things that are found in the census data. We want to make sure that you're able to access a lot of data from different perspectives so that when you're looking at specific populations or drilling down by race and ethnicity or age, gender, that you have all access to data. So if you are interested in learning more about utilizing that particular set of data, please let me know. You can email me at any point in time, mmoch@kyha.com, and we will get you access to that additional information as we feel that it is very helpful that you have as much information and data to look at this readmission.
Thank you, Melanie. That was a great overview. And as you can see, we can look at readmission data by many different cohorts. We're specifically working with several initiatives, as we mentioned with the QIO, which is Medicare, the Medicare view. We're working with others where the view is for Medicaid. But obviously, if you're doing if you're paying attention to your readmissions, it makes very little difference which payer is paying the bill. Everybody is interested in reducing readmissions, particularly those that are clearly preventable. I want to move along to the next part of our readmissions checklist. And again, We have found this one to be a significant a significant help in allowing for readmissions to become a community effort. None of those patients that you are serving in your hospitals are just your patients. They belong to the community. When you discharge them, they are being discharged to other post-acute providers. They're being discharged to family members. They're being discharged to other caregivers. And all of the patients in your community are the responsibility of all the caregivers. So if you have a patient that has been a particularly difficult case in your facility, you can bet that patient is going to be a difficult case when that patient is transferred or transitioned to a home health agency or to a SNF or to some other kind of post-acute provider. So one of the things that we've been focusing on is this item in the on our checklist, which is to collaborate with post-acute and community-based providers, including SNFs, rehabilitation facilities, long-term care, acute care hospitals, home care agencies, palliative care teams, hospice, medical homes, and pharmacists. And then we're going to talk a little bit more about how we've been institutionalizing those through our work with QIO Allegiant Health. At this point, I'd like to ask some of our other hospitals who have been working in this area for quite some time to give us a little bit of a perspective about the communities, about the coalitions in their area. And I'm going to call on Lisa Halliday first. She's with Taylor Regional Hospital. I know, Lisa, you're on a phone that Zoom calls are a little bit iffy in your part of the state, and we appreciate you being there. Are you there?
I'm here, Charlie. Can everybody hear me okay?
We can. Thank you very much for being there. I want to ask you, first of all, let the audience know what your title is there.
I am the care management director here at Taylor Regional Hospital. We cover utilization review, social work, discharge planning, and all other assigned duties.
Yes, well, that I'm sure everybody has that in their job description as well. We have been involved with the coalition in your area for quite some time, and I've been impressed with how you've connected to your community. Of course, Taylorsville is a very engaged community to begin with. You've got a lot going on there, but could you? Was there anything particular during the COVID time where you found either new paths to transition, or how you were able to rely upon your post-acute providers even in a greater way during the pandemic?
Well, we couldn't have survived it, I don't think, without our post-acute providers. We have, like you said, we have been involved with the KHA and Q-Source since 2016, and once we started those coalition meetings, we were meeting face-to-face. We had a subgroup meeting where we would meet monthly, and we would discuss more on an intimate level, individual patient cases, what could the hospital have done differently during the transition care, to make sure that they all had the information they needed so it would be seamless. But during COVID, of course, we had our liaisons, our nursing homes, and our acute rehab facilities, and our home health providers and hospice were coming into the hospital and actually going to the bedside with the care manager for a soft introduction, reviewing the home health or the post-acute plan of care with the patient and the family, making that contact smoother so everybody would be on the same level when the patient did transition to that next level. So that was the main feature I think we were missing, was that soft handoff and that face-to-face contact. But
yeah, go ahead.
So we continued our sometimes multiple times a day calls. It was like you said, people were not coming to the hospital as much. Our home health referrals, I think, declined because they didn't want people coming into their home. They didn't want people were afraid to go to the nursing home. They'd heard the rumors. I'm going to be in isolation. Nobody's going to be checking on me. I won't get the therapy I need. If you send me there, what's going to happen? I'm not going to contact with my family, and that's not going to work for us. So fortunately, most people were not doing public jobs at the time, and we were able to be a little creative with some of the other agencies and work on plans together for these folks. And we're able to get them home with services that they would allow to come. But there was absolutely no hesitation from any of our post-acute care providers about taking these folks that were COVID positive and getting them out of the hospital and onto that next level of care, except for the nursing homes, and God love them. Sometimes their rules were changing 2 and 3 times a day. It was multiple contacts with their infection control people, our infection control people, and we didn't really have the testing available to be able to do what they were requiring at that time. So there was some lengthy delays on those parts as well. One good thing that did come out of it, though, we have had more Zoom calls, more conferences that way. It's easier for us to communicate with people. Casey County, for instance, the nursing home over there, we have quarterly calls with them now on the phone and on Zoom calls, and it's been seamless so far. I think it's worked for both of us as far as their new programs and their ability to be able to take our patients. I feel like I'm rambling.
No, you did a great job. And what you've illustrated, a couple points that I wanted to reinforce. One is that when you already had an established relationship with many of your post-acute providers, but this COVID thing kind of put everybody in the same boat and reinforced the point that I made earlier, which is that these are all our patients. They belong to all of us. And so by you bringing folks into your facility to do the warm handoff bedside, I imagine did a great job at, first of all, being able to move those patients to the right level of transition once they were able to be discharged. But more importantly, gave the patient and the family a tremendous sense of relief and security that their loved ones are going to be taken care of. I mean, that's not something that you would reserve just for a pandemic. I mean, that's the kind of care you want to give all the time. But again,
Right.
you knew those people, you knew those providers, and they were willing to understand that the patient belonged to everybody. The other thing that you mentioned that is so important that we have found in many of our coalitions is the question that you ask of them: am I giving you the right information as I'm transitioning this patient? We have found over and over again that oftentimes the receiving entity doesn't have all that they need, and we've seen how devastating that can be if they all of a sudden realize, well, this patient is this, or can't speak English, or has family members that cannot assist, or one thing or the other. And so the more information that can be passed along to the post-acute providers, that transition time is very, very helpful. I want to ask you one other question, just because it's always a great story for your particular area, and that has to do with transportation. Just tell us a little bit about, you've got a phenomenal support system there with regard to transportation. If you could just highlight it a little bit, and were there any changes that you had to come up with during COVID?
Well, we do have a hospitality van here. We've had that van service in place, goes all the way back into the 90s. With the service used to just carry patients. When we didn't have a cancer center, it would carry the patients for radiation to James Graham Brown for radiation. So that's kind of how it got started. I think through the years and through the needs assessment, transportation for healthcare became more of a community-wide concern. So our first van was donated by our hometown hero, J.B. Holmes. I don't know if y'all are big golfers or not, but J.B. is a Campbellsville native. So his dad donated when he would transport him all over the United States for golf tournaments. That's the van that we got initially. So after using that van, and they saw how what an asset it was, not only for the hospital, but to the health and safety of our community. Then they held a gala. With the money from the gala and the charity, they were able to purchase another van. And since then, yearly, we have golf scrambles. They were able to have it during COVID, if you can believe that. Of course, it was outside at the country club here, and they followed all precautions. And we're now running 2 vans. And the golf scramble buys a new van every year to keep that on the road. They have local sponsors, local fuel sponsors that cover as well, and we have advertisements for the fuel sponsors on the van. So some of the things, they had to be creative as well to transport these folks with all the precautions. And I can't say enough good things about our hospitality director, Cindy Rose, and our infection control director, Shannon Davis. We just have such a great team here at the hospital. We're so proud of everything that our team can come up with creatively. So they worked together, and they were able to fit the van with our maintenance department, fit it with plexiglass so that there was a barrier between the driver and the passengers. They cleaned the van before and after each passenger was picked up and dropped off. And as Cindy brought me some numbers yesterday after Charlie had mentioned that he was going to ask about this. And for Taylor County last year, looks like just to the hospital alone was 1,379 trips. Their total was for all counties. They travel Taylor, Adair, Greene, Marion, LaRue, Boyle, Casey, Washington, Russell, Hardin, and Fayette. And initially was just bringing in cases for outpatient testing, diagnostics, outpatient surgeries. And now we've gone on to, with EMS being so overburdened as well, if it is safe at all for us to transport our discharges to our local nursing homes or to home, sometimes we will even send a nurse to ride with them just to make sure that the transportation, the driver is okay with it and the patient does well to get them home. Total trips for last year, 2,309, and she did tell me that was down some. But they bring them into our physician offices, sleep center for those sleep diagnostic tests, dialysis. Dialysis is not part of our team. They're part of our team, but they're not employed by the hospital. So that helps us tremendously with these dialysis patients who couldn't get transportation any other way because they only have Medicare, and Medicaid transport is limited around here. We don't have taxi service, although I have heard on the radio recently that we are going to be having Uber and Lyft. So I don't know if those will be added to the list or not, but yes, the hospitality transportation has been a game changer.
Well, thank you. Absolutely. That's phenomenal. That as we talked with other communities around the state during COVID, transportation always was an issue. It seems to be an ongoing problem in so many places, and it was made even worse, as you suggested, by the fact that EMS and other kinds of transportation were limited by the numbers of patients they could take. And one of the patient groups that was the hardest hit by that were those that were needing dialysis. So your story always resonates with us, and I appreciate, Lisa, you being on this morning and describing this for all the rest of us. And thank you again for all that you do, and thank your wonderful team there on our behalf.
Well, thank you for having me. It was my pleasure.
You're quite welcome. Our second hospital that I wanted to talk about is from Baptist Health Hardin, and let me introduce Becky Deaton. Becky, first of all, tell the audience here what your title is, what you do.
Yeah, Charlie. So I'm Becky Deaton, and I am the Director of Case Management here at Baptist Health Hardin, and I've been with the organization for about 22 years.
All right. And when we first began meeting in your hospital with some of our community meetings, I couldn't help but notice some of the issues that the hospital and the post-acute providers were all having, and that had to do with some of the more difficult patients, the patients that for whom mental health was an issue and or substance use disorder was an issue. And I remember vividly you reporting at one of those meetings about a method that a model that you had come up with where you were embedding someone in your ED to help triage that. Could you describe that for us and how that came about?
Certainly. So for those of you who may not be familiar, so Baptist Health Hardin is located in Elizabethtown, Kentucky. We sit right off to the side of I-65 in between Louisville and Nashville. We service a 10-county service area, and we've got about a 300-bed license for 300 beds, although we usually run in the probably 200s. Our emergency department is the busiest in the state. And we, on average, prior to COVID, we're seeing anywhere from 215 probably to 240 patients a day in our emergency department. So our setup from a case management perspective in the ED, and this is going back to 2018, our setup was we had a nurse who specialized in utilization review, and then we had a social worker that did discharge planning. We had a relationship with Communicare, which is our local state-funded mental health provider. And they would come over to the ED to complete assessments on patients in which the ED provider just wasn't for sure what was the best route for that patient. Those that were clear cut that we knew needed inpatient hospitalization, that's not the type of patients that Communicare would see. It was just those that were somewhat vague. So we were spending a lot of money with Communicare, and then we also understand that Communicare has normal business hours in which they see patients all day long. So that would delay their mental health evaluator's response to the emergency department. After hours, they of course are the MIW assessor. Again, that would trump anything that was going on in the ED. Myself, at the time I had Stephanie Green, who was our social worker supervisor. She and I worked together with our ED leadership to propose to, actually it was our chief financial officer and our chief nursing officer, what behavioral health looked like at Hardin, what it looked like in our community, and for us to consider putting a licensed clinical social worker, licensed professional counselor in the emergency department to do these assessments. And Stephanie put together a wonderful presentation. We presented, it went to senior leadership, and then in 2019, we hired our very first clinical social worker who would do those assessments. We put her in the hours of peak ED volume. So I think when she first started, we did a 3P to 3A, 3 days a week. And it was within no time that we noticed, we've got something here. We can do some real good with this. The ED physicians were totally on board, as was the staff. And current day, we have 2 of those individuals. So we run them 6 days a week. We don't have coverage on Sunday just yet, but we've got 2 social workers. Their master's prepared. They just haven't gotten their clinical social work. They're going to be working on that, and we hope to be able to run every day. It lessens our expense with Communicare. It lessens Communicare's burden of having to come over here. And ultimately, it is optimal for that behavioral health population.
Absolutely. And you've had tremendous success with that. Did that hold up? Did that model hold up pretty well for you during the COVID period?
So yes, during COVID we did. Now our emergency department, like everybody else in the state, we saw decreased volumes, but we did continue to keep that individual working and on site. Again, we're back up. We've pretty much returned to those pre-COVID volumes in the emergency department. So I would say we are back to business as usual.
Well, that's great. And obviously you've pointed out many of the cost benefits of that. I mean, first of all, it frees the other providers in your ED from working these very complex cases. And at the same time, it gets the patient where they need to be to receive the best care and the most help. One of the things that we've also done since this coalition has been rejuvenated in the last several months. We've been focusing an awful lot on behavioral health. And could you describe for us the relationship that you have with StepWorks there in town? Because they seem to be a very major player in what happens to the patients, particularly that have behavioral health or substance use disorder issues.
Yeah, so in adjacent to Hardin, literally within probably less than a half mile is StepWorks. They've got several buildings in town. We have had a great relationship with them. We continue to have a great relationship with them. Of course, during COVID, it was a little different. Those folks couldn't come in and do the assessment if they felt like they needed to. We have returned now to allowing our liaisons back in the building. We even had, now we don't current day because we have just went from being a county-owned facility to owned by Baptist, but at one time we even had a software that we shared that StepWorks was one of our first to join, I guess, that agreement. And they could even see when their previous patients would present to the ER and be able to reach out to them, particularly if it was a substance abuse issue or behavioral health, and work with the patient that way. We hope to get that back. There's a couple of, with being Epic, there's a couple of different products that we can use. We're not there yet. So right now it's more so of a telephone handoff or assessment.
In my understanding, with StepWorks, we've heard several presentations, but they're a residential facility. So I would assume that your relationship with them is for those individuals that need more intensive kind of behavioral health intervention. Is that correct?
Absolutely.
And I also know, and I'm not. We're mentioning them because they've been prominent in your area, but you've got a tremendous. I mean, you've already laid out your location and how easy it is to access your hospital and the types of patients you get, and so we know that the number of patients that are in need of behavioral health care is exponentially higher in your area for a number of reasons. Some of them are not even your patients, and we've heard from the coalition meetings that the people are coming in from other parts of the state or out of state to receive care during these very difficult times of COVID. So it's all over, and you're doing a phenomenal job in working through all these very serious issues with all your good providers. Anything else you want to say about your behavioral health program?
No, I do look forward to what we're going to be able to do with these upcoming social workers that are working on their clinical supervision. I would say I've been in my role for, I believe, since 2013, and I am, I guess, very proud of the work that we're doing in the emergency department. And I think that would be echoed by their leadership as well as their physicians and nursing staff.
Well, thank you, Becky, so much for being on and today and talking to us about this. I couldn't agree with you more with regard to the value of the social worker in this business. And to prove that point, we have our own and here at KHA, and for that very same reason, we have seen the value not only that social work brings to the case management world, but also how they can assist us with the development and nurturing of these communities. And so I'd like to turn it over now to Kayla Rowe to talk about our communities and their value in the patient care.
All right. Thank you, Charlie. KHA partners with Alliant Health Solutions to create, nurture, and provide content to communities of providers for the purpose of improving local healthcare and collaboration. This partnership aims to support local community efforts to improve local and mutually agreed upon goals such as chronic disease management, care transitions, patient safety, and behavioral health. These communities provide a collaborative model to address community-specific issues with a broad range of community partners. Topics around social determinants of health, such as transportation issues, homelessness, food insecurities, have been brought up and discussed during these community coalition meetings. We have community partners that have been able to come together and they've been able to share best resources or create a plan of action when needed in overcoming these barriers. Community coalitions are a chance to connect healthcare providers and community-based organizations, as well as support the CMS quality goals with innovative, evidence-based, data-driven interventions that maximize meaningful patient and family engagement and address the social determinants of health. On this slide, you'll see the quality improvement goals. These are the four goal areas for the communities, and these are set by CMS. I'm not going to read these for you word by word, but we'll leave these up on the screen for you to take a look at. Here you'll see the Kentucky regional communities. There are 8. We have the Purchase Area Community, Hardin, Taylor, Meadowview, Fleming, Corbin, Hazard, Eastern, Northern Kentucky, and Lexington. The dates beside those communities are upcoming coalition meetings. If you would like to attend a upcoming community coalition meeting, feel free to email me at kroe@kyha.com. Again, here, if you are interested in attending a community coalition meeting within your region, you can reach out to myself, Charlie, Melanie Mock, or Emily Henderson, and the emails are located right here.
Thank you, Kayla. Now, you've come to us from a career in case management yourself, and one of the things that we understand in our work in readmissions, and one of the reasons that these coalitions and/or relationships with post-acute providers is so critical, is because there is no one solution that solves each problem. And many of the patients that you have seen, that our case managers have seen, are very difficult cases, or complex cases, or they're cases that are presenting barriers that we hadn't expected. Can you describe a situation that you had run into where you had some barriers that you had to overcome in your work?
Absolutely. I had the opportunity to work with a gentleman, and he was the sole caregiver raising 2 of his grandchildren. But he was struggling with missed appointments and getting services that the children needed, which is why he came to me. We received the referral. But one of the barriers that we discovered was he was unable to read or write. He would receive text message, appointment reminders, which he would say he didn't understand or he just ignored. But we were able to get those switched over to phone call reminders. We ended up being able to assist him with filling out paperwork for behavioral health services, filling out a SNAP application, getting the medication blister packs delivered to the home, daycare assistance, incontinence supplies. This is just a different, wide array of services to set up for him. But we received the referral, like I said, because of the missed appointments, but by helping resolve and address some of the other issues causing those missed appointments, we were really able to help that family.
Well, and we see that over and over again. And oftentimes, non-compliance, we simply check that box and say, this is a non-compliant patient, but we have no idea what's causing that problem. And in your case, obviously, being able to read and write is critical to being able to understand not only discharge instructions, but prescriptions and other kinds of written instructions. And we just make an assumption that everybody can read and write, and that's often not the case. We've heard cases where some of the hospitals have worked very, very hard to get people to quit smoking, but they go home to a household that is of smokers, or they're trying to convince them to eat better, but they go home to a household where they are totally dependent upon another person to fix their meals, and that person needs to be educated as well. So we understand that there's often not just one solution for improving our discharges, and your case illustrates that. And I've heard those same kinds of stories from most of the folks that we've worked with over the time. And again, it reinforces how important social workers are in understanding the complexity that people are working through to try to achieve better health. So thank you very much. We look forward to your contributions in previous meetings, and Kayla is our champion with regard to setting up and inviting people to these community coalitions meetings. And we've had a great deal of luck recently at inviting a whole smorgasbord of individuals to participate, including MCOs, including transportation folks, including people who work with food banks. All of those are critical to successfully transitioning patients from an inpatient setting to home. So please be aware of the coalitions in your area, and as we get those last three set up, we'll make sure that the hospitals in those areas are fully aware of when those meetings are going to be held and who the principal partners are to help formulate those coalitions. So thank you very much. And now I'm going to turn it to Melanie to give us a quick overview of some of our other quality programs here at KHA.
Yeah, thanks, Charlie. And I just want to add, that collaboration and partnership with the Medicaid managed care companies has been just overwhelmingly successful so far. We knew that they had a bunch of resources that really for their members, but it just wasn't available to all of the hospitals. And we've been inviting them to the community coalitions, and we're learning about these great resources that we are able to provide to patients. Especially around the food insecurities. There's, free meal plans. They have rent assistance programs. So as we continue these community meetings, we are inviting those folks to the meeting so that they can share those resources for you all to understand what's available to the patients even before they get discharged from the hospital. So it's been a great partnership. As Charlie said, I wanted to mention just quickly what all the quality initiative programs that we have going on currently at KHA or hope to have going on, where this touches readmissions and transitions of care. So obviously the community coalitions, again, touching readmissions, transitions of care, but it's also touching, the opioids and behavioral health. Our partnership with iPro, with our HQuick work, this is that next level of what used to be the HEN work. Transitions of care and readmissions is a part of that program. Also, our Kentucky Rising Stars program, really looking at how to increase our CMS star ratings. And we know readmissions is a huge portion of that. So again, touching that program also. And as I earlier mentioned, the hospital rate improvement program, if that does get approved by CMS, that also has a piece of readmissions in there from the Medicaid only standpoint. So in saying this, when you submit your data on readmissions, it's touching every one of these programs. It's not just touching the coalitions, but it's touching all of these different programs. So we wanted to make sure you knew where your data is kind of going for all the programs that we have going on. If you're not familiar with one of these programs, please let us know. We would love to have a conversation to get you engaged in any of the programs that we have currently going on with our quality program here at KHA.
Thank you, Mel. Questions from you all that we might answer?
And please feel free that you can either speak up or you can put it in the chat box.
You'll see in the chat box a reference to the Kentucky Sepsis Consortium also being able to help readmissions. We're sorry you couldn't see the slides earlier. Remember that all of these will be available to you. I think you were going to email them to everyone so that you'll be able to see them later. And of course, we've recorded this presentation in its entirety, so you'll be able to look at all of that. And again, remember our checklist, which is in the chat box for you to download. And as we move to other webinars in this series, we'll be focusing on other items on that checklist. But we thought that these were the two most important as we began to re-energize with regard to readmissions. Questions from anybody? All right. Going once, going twice. Thank you all very much for your time today. And I also want to particularly thank Lisa and Becky for presenting today and being available to us. There are 1,000 stories in hospitals about what's going on to reduce readmissions, and hopefully we can get to a lot of them during our work on readmissions. But I thank those two particularly for being on today and helping us get reset on preventing readmission. So again, thank you all very much for being with us, and we hope to see you at some of our future meetings.
Thanks, everyone. Have a great day.